No. Yeah, so this is the first case. In the last session, one of the candidates asked about difference between uh, septic picture and CML, but unfortunately, she is not there today. So this is a 46-year-old male admitted to ICU with biliary sepsis. The white cell count is 44 and the platelet count is 600 and hemoglobin is 99. This is power 10.
After neutrophilia.
Yeah.
Thrombocytosis.
What is the HB?
HB is 99. We'll go to higher power to see the cell.
Target cells?
Yeah, I will. Yeah. So how a lab person will report it? Let's see a few more sections and then if a
You say
lab
neutrophilia with thrombocytosis, query sepsis. There's platelet anicytosis. You know, there's one or two spherocytes about too.
I think the neutrophils is showing toxic granulation also.
Yes, there is thick granulation in the neutrophil.
It's not a typical toxic granulation, no. Anicytosis, so that goes with the anemia. I thought there might be a few monocytes about, but I haven't seen one yet.
Trispocyte.
What's the CRP?
385.
Oh, that's okay.
Yes. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Yeah.
10 seconds.
Yeah, hypersegmented neutrophil.
What's his B12 folate?
B12 was normal, but the folate was low, 3. Less than 4 is low in our country.
This neutrophil, I think you just skip from, is bilobated, maybe dysplastic, this one.
The connecting nuclear material is not very thin, but you do see some neoplastic, dysplastic neutrophil in sepsis as well. So I will make this neutrophil big to see if these are death crystals or just shadow. No, saying this is just the shadow of the RBC behind it. I was thinking maybe these are the death crystals that are present in the severe sepsis.
That's at the latter stage, though, isn't it?
Mhm.
It's not a good sign. It's organ failure then.
Yeah, if there is multi-organ failure, then these death crystals do appear. Uh,
One more hypersegmented neutrophil.
folate deficiency. The patient had low folate, so we thought that segmentation is because of the low folate. This patient coagulation screen was abnormal as well. So
what was the fibrinogen?
the gross fibrinogen was low. It was 1.0 or 1.1 like that. In severe sepsis, we should expect fibrinogen to be like 4 or 5 because it is a inflammatory response uh, thing. It should be high in the severe sepsis or infection. And if it is 1 only, then that is low as well. This patient is in DIC because of the abnormal coagulation picture, and uh, there were 2 schistocytes.
I'd expect to
And
see more fragments, though.
yes, that I was looking for, but I could see only 2 up till now.
The platelet count's still quite high.
Platelet counts are high. You can say this is also a schistocyte. Yeah, so
You see a bit of hypochromasia. Reds.
here in this section, because of DIC, he is hemolyzing his blood, and I think iron content is going low as well. But I do not remember the iron level of this patient. So in DIC, you do see fragments. The platelet count will be high because of the infection as a reactive response. The white cell count will be high, but it will be mostly either neutrophil or band form. Sometimes myelocytes do appear, but not always. And you need to check the coagulation profile as well to see whether it is DIC or not. There is a dot here which means this blood film relates to female, right? This is a bar body,
Yeah.
if I remember correctly.
Yeah. You sometimes see dull bodies
Sorry,
as
I'm
well.
here.
What happened? Sorry.
No, sometimes
Sorry,
you
yes, I'm asking
see.
about this.
Sorry, carry on.
Thank you. It's just asking about the thrombocytopenia because it's part of the MAH of the DIC. Maybe early in sepsis, the thrombocytosis, but of the DIC, it might be more thrombocytopenic.
In DIC, if it is because of the bacterial infection, then sometimes you see thrombocytosis as well. Thrombocytosis is common in bacterials. If it is a fungal or viral related sepsis, then you will see thrombocytopenia. Or maybe this is the initial stage, that's why his platelet count is high.
Yeah.
But as a response to infection, the platelet counts goes high always. But if it is a virus thing, virus always suppress your bone marrow, and uh, there is thrombocytopenia. One fragment is there.
Yeah, it's just a site.
No, sure. So you will report the blood film for the exam purpose that uh, this this blood film contain leukocytosis and thrombocytosis. There are multiple schistocytes in the blood film, no blast seen, multiple uh, toxic granulation in the multiple toxic granulated neutrophil and band forms seen. There is platelet anisocytosis. The impression is likely reactive response to infection. Please correlate clinically or check the infection marker and coagulation screen for the thing.
Yep, that's about it.
Yeah, so normally the people in the exam make a mistake. They see that the white cell count is 50 plus, so this must be a CML, and they make up things. So high white cell count doesn't mean that this is CML always. It can be a reactive as well. Now to compare the previous slide with this slide. Yeah. So this is again a young person, 30-year-old with a white cell count of 400.
Can we have a closer look, please?
Okay.
So you go this for plastic picture.
I think this is CML. It's different. There is lift shift. There is myelocytes, metamyelocytes, bands.
So this one is a neutrophil. This is a band form. This is a myelocyte. There is a dip here, so it can be a metamyelocyte. This one is a myelocyte. This big one is a promyelocyte, and we have yet to see a blast. And
There's the blast down, I think, here, this field.
I haven't seen any basophils yet.
yeah, NRBC because of the high bone marrow activity, and looking for basophils.
I see one there now.
Yeah, this one looks like eosinophil,
Yeah.
orange granule, and in this one basophil is not there. Okay.
There's a couple there. Not more than that.
This one is
Yeah,
very
see three
granulated,
there.
and this one as well is very granulated. Not sure about this one.
Yeah.
Yeah, and this one is gloss. This one as well. So they can ask you in the exam uh, the difference between a CML and leukocyte picture in the blood film. So you have seen the previous blood film whose white cell count was high, and this blood film whose white cell count is high as well. There is eosinophilia, basophilia, and whole myeloid peak, which you didn't see in the septic picture of blood film. And the basophil is the main differentiating point between uh, leukomoid reaction and the CML.
Why are there more basophils seen in CML?
The 922 translocation and mutation result in formation of all myeloid peak, including basophil, eosinophil as well. This is the only explanation we think for it. So how will you report this blood film?
Can we see a lymphocyte just to compare with the size of RBC?
Lymphocyte,
Yeah,
it would be very difficult because the film is full of myeloid peak. Uh, Maybe this one is a lymphocyte, but this one is NRBC. This one looks like a lymphocyte, and its size is almost same as the NRBC, as the red cell, and the size of
But
the nucleus is same as the red cell. This is normocytic.
yeah, so normocytic normochromic anemia.
Always comment on the abnormality first.
Okay. We'll say neutrophilia or leukocytosis with the bands, metamyelocytes, myelocytes.
Mhm.
I think the blast should be noted as well.
Yes. The blood film contain leukocytosis. There are multiple neutrophil band formed metamyelocytes, myelocyte, promyelocyte, blast form, multiple NRBC along with basophils and eosinophil. Platelet count is slightly increased. Red cells are normal. The blood film picture is consistent with uh, most probable diagnosis of chronic myeloid leukemia, or you can say it is most likely a myeloproliferative neoplasm, probably chronic myeloid leukemia. We need to send peripheral blood for uh, BCR ABL1 screening. So you will confirm the diagnosis by BCR ABL1. Then in further part two short questions, they can ask you what are the poor prognostic factors in CML? What are the prognostic scores in CML? And
We have SOCAL,
yeah,
tool, EOS,
UTOS,
EOTOS, yeah.
yeah, HASFOLD, and ELTS. The current one that we use in practice is ELTS, and uh, there are some poor prognostic cytogenetics which are called major root abnormality. And then they can ask you about treatment options, what to use as a first line in these patients. They can ask you what is the criteria of treatment-free remission that we discussed in our yesterday's session. So reporting usually carries 5 marks, and the rest of the marks are for these small questions. CML is quite common. You must have blood films in your trust or in the NICPOS folder, but it do come either in a Viva or in a short question in the part 2 exam. So you have 9 minutes in the short question, and in these 9 minutes, you have to see a blood film and you have to answer the question as well. You need to be very quick in the exam. So this is a 40-year-old lady with a hemoglobin of 180, and white cell count of 13, platelet count of 380.
That's polycythemia.
Yeah. I would like to ask you if you can tell your colleagues how did you find this is polycythemia? What are the features that made you think about this is polycythemia?
Well, the actual red cell count looks really high. Hematocrit's probably high too, by the looks of it.
Hematocrit above 49 in female and 52 in male.
Hmm. So one clue is that they will give you uh, FBC, which will show either high hemoglobin or high hematocrit. Second clue is that the red cell mass is very high in the blood film, and you can see these red cells have uh, different shapes. Like this is called stacking of red blood cells. Like you are keeping bricks on on the top of one another. So they have different uh, side shapes. Some are straight, some are regular, round one, because the mass is very high and they are compressed together. In the other blood films, they were all normal red blood cells, but here they looks like you have um, pieces of marbles in the wall with different side shapes, or in the books, the term is mentioned as stacking of red blood cells.
That can be quite misleading because you could think it'd be a ruler, because that's another term for stacking of coins.
Mm. The ruler, these are attached to one another.
Yeah.
One is not attached. Uh, if you can see these red blood cells, they have made different shapes according to the neighboring RBC. They looks like compressed to one another.
Mm.
Like this is not a regular shape of RBC. This is not a regular RBC shape. This is made because they are too much and they are trying to adjust themselves here. So what will be the next step after seeing this blood film?
I certainly requested Jack too.
If I say no, I don't want to request Jack to, there is something else that you need to do.
Examine the patient for splenomegaly.
Why?
Suggestive of myeloproliferative neoplasm.
So whenever the counts are high, do not jump to MPNs directly. There is
We rule
always a there is
we rule
always a
out
secondary cause.
secondary causes, like for example dehydration. Is the patient dehydrated or no? And then we go for smoking, OSA.
Yes, the patient may be very obese, may be having um, sleep apnea, smoking, taking steroid for gym, maybe having a COPD or any known uh, solid organ cancer secreting a lot of erythropoietin.
It
Or
could be.
maybe he has this diagnosis since birth, congenital polycythemia. So always exclude the secondary causes of erythrocytosis, and then you can send the jet2 for the patient. So this, if this patient is a smoker, then refer the patient to GP for smoking cessation program. If it helps the if the program helps the patient by quitting the smoking, his cell count will come down. If the patient is known to have COPD or sleep apnea, variogy, or any pathological cancer, his count will be high. The main important thing here is to check EPO level of this patient. If the EPO level is low and cell count is high, it means there is some malignant element is involved. If the EPO level is high and this is the blood picture, then I would think this is secondary polycythemia, because that cause leads to elevation of erythropoietin, and now as a response, the uh, red cell count is high. Similarly, in thrombocytosis, you exclude first the secondary cause. The commonest cause of thrombocytosis in UK is iron deficiency anemia or infection, and rule out the other causes. If no secondary cause found, then you contact the HMDS for MPN panel or JET2. So if you jump directly to uh, MPN panel or JET2 in the exam, they will not give you marks, because in our routine practice, whenever we have high counts, we always ask them, is there any secondary cause in this patient or not? We open the Boko app, and the Boko app has uh, causes of these things. I hope you know about Boko app. It is very good app for hematology on call. So the next blood film is 24-year-old male with uh, fever and cervical lymphadenopathy.
Sorry for interruption. So Boko Abbott BUKU?
BUKU.
Great, thank you.
I'll show it to you. This one. Book medicine. and it has different specialties, uh, including hematology as well.
Yeah, there is an application also. You can download it to your phone.
Yes, there's a Bookco app. You can download it from the application store.
Great, thank you.
This is lymphocyte.
Yes, so this patient has lymphadenopathy, and this is the blood picture.
Can see large platelets.
The platelet is a bit low. So what comes to your mind when you have a 24-year-old patient with cervical lymphadenopathy? What are your definitions?
Infectious mononucleosis, other viral infections,
Mhm.
lymphoproliferative disease like lymphoma, and yeah, this is what came in my mind.
Which lymphoma comes to your mind?
Hodgkin.
Yes, Hodgkin is common in young age. All your Hodgkin, all your Hodgkin patients will be less than 30,
Yes.
and they have either a cervical lymphadenopathy or mediastinal mass. So this is a quite large lymphocyte, but it has a basophilic cytoplasm, and it is developing this RBP, and this is a mature one, and there is no blast in it.
What is the lymph count?
Lymphocyte count is the white cell count is 13. The lymphocyte itself is 5.
That looks a bit atypical. It's molded around the red cells.
So this is another phenomenon called scalloping of the red cell. Cytoplasm is basophilic. There is no nuclei, no nucleoli in this cell, and these are the features of reactive lymphocyte or atypical lymphocyte. So what test you will do to confirm your diagnosis?
Flow cytometry.
Flow cytometry. Why? To exclude what?
CLL, most probably.
Sorry? To exclude what?
Usually we use the flow to exclude CLL. Or we can,
Um,
yeah, other markers also for the B cell.
um, CLL does not appear like this. CLL has a very small lymphocyte
Very small
and
clear cells. Yeah, it's not like this.
very small lymphocytes. Usually the size is just like the red cell, and they are quite many. Like the CLL counts are always about 20. Extreme cases are in 300, 400 as well. And CLL doesn't happen in 24-year-old child. Patient.
This is reactive lymphocytosis. I will think about EBV infection.
Yeah. Monosport test.
Monospot test, yeah.
Yes. And to exclude other infection, you will send HIV serology, hepatitis B and C.
What's the CRP like?
CRP were just 25, I think, in this patient, as far as I remember. Because it is a virus, the CRP usually does not go high.
Hmm. It's not a classic case, though.
Sorry?
This is not a classic case of like glandular fever. I'd expect bigger cells,
Mm.
more
They are of
atypical,
medium size.
and more basophilic cytoplasm.
Yes, maybe this is it. I think this is the biggest cell up till now.
They are
Yeah.
biliopic as well.
Mm. And there is no other bigger than this cell. That one, that one was the biggest one, and this is another one which is big. It depends on the virus as well. If you have seen the blood film of a whooping cough baby, it has a smaller cells with deeply basophilic cytoplasm, just like the cytoplasm of Burkitt lymphoma cells. It depends on the virus as well. So this is quite large cell, and the cytoplasm is bluish. There is no nucleoli, no granules even, and there is typical scalloping here, this one, and that one, and the history matches uh, infectious mononucleosis as well. Yeah, so this is a 70-year-old patient with progressive fatigue, and paraprotein was 66. We thought that this may be myeloma. We did a bone marrow biopsy for her, and this is the aspirate, which is particulate. You can see the particle here. So this is power 4. Aspirates refine and suspected blood film of a worm. You need to see on power 4 first. For the aspirate to see whether there is any particle or not, the worm blood film, you will see the worm on power 4 first, and refine at power 4 will tell you the cellularity of the tip. So this aspirate is quite cellular. You can see a lot of cells here. This was particulate as well. And let's find a thin area to see the cells. See what do you think of these cells? All right. So this is the thinnest area in this aspirate. Any comment on this aspirate? There is neutrophil. There is myeloid maturation is present. These are few lymphocytes. What is this cell? This one, that one.
And those are nuclear RBCs, aren't they?
I think this is a plasma cell.
Now make it big for you. Mm. This was the cell that I was talking to about. This one. This is a one-sided nucleus, cytoplasm, and a halo here. This is the plasma cell.
Yeah.
NRBC, NRBC.
That's a plasma
Uh,
cell. It's got the egg shape.
mm,
Fried egg.
plasma cell. There's quite a lot here. This one, these one. These are dysplastic plasma cells with two nucleus. These are all plasma cells. This patient had 40% of the plasma cells in the bone marrow, and the CRAB feature was positive. CRAB mean um, calcium was high, renal functions were abnormal, anemia was there, and there were five uh, lytic lesions on the low dose uh, whole body CT scan. And the paraproteins were IgA as well. It fits the criteria of myeloma, and she had 14-16 translocation, which is relatively considered as a poor prognostic.
Was there a plasma viscosity done?
The plasma viscosity was 3 in her case. Because she was already on a blood thinner for a DVT. So maybe that's why the plasma viscosity was a bit low.
Sorry, Amir, is it the flame-shaped plasma cell for typical for IgA?
The flame shape is usually, which I have seen common in the Waldenstone, but the book have mentioned flame-shaped cells in IgA, but I have
IgA,
seen
yeah.
yeah, but I have seen most of them in the Waldenstrom bone marrow, uh, not in any other case. Like these are plasma cells, but this is not flame-shaped. Only these few projections here, but I will not call it them as a flame shape, typical flame shape.
I think there
Typical
is couple like with the spindle.
projections, yeah.
Yeah.
But most of them are without any projection. You can you can remember it for the exam purpose. But my practical experience in terms of flame shape is like this one has many projections.
Mm. And the
Now this
top
one
left,
is
both these, yeah, it looks more of flame shape.
here. Sorry, I don't have the trifine of this uh, patient because bringing out trifine is a bit difficult because of legal purposes. Aspirate, we can stain aspirate cell in the laboratory. We bring out aspirate. This is a giant plasma cells with some protection. Eccentric nucleus with uh, halo and projection. Now, there these cells have some vacuole inside inside them. This one and this one. There was a term used for these cells, Ditcher bodies or something like that, but I forget.
Yeah, those are bodies.
And there was one another term as well because one of them is intranuclear and another of them is intracytoplasmic. Is many of them, but those are the features of Waldenstrom, uh, uh, not commonly seen in multiple myeloma patients. Right. So we are on time today. We have done 5 cases, so we will stop here. Is there any question?
Thanks again.
So next week there will be no morphology session. It will be session for the part two people, how to prepare part two. After that, we will resume our morphology.
Thank
Okay.
you. Thank you.
Okay, thanks, mate.
Thank you.
Welcome. Take
Thank you.
care.
Appreciate it.
Bye bye.
Thank you.
Bye.
Much appreciated. Bye.
Thank you.
Thank you.